to plan here. So what is for the next year is already planned. We cannot change. So we have to plan for 2 years. You are as in the faculty, so you will have different. You can write professor AC. As I wrote, right? AC. A contract. You can spend as you want.
You can put it on your LinkedIn.
4, 8, 10, 12. Super!
Yeah.
Super! Less than 10 minutes is in time. Because if you think that I spent 40 minutes from walking distance of 5 minutes, 6 minutes, when you told me I was in the half. So 40 minutes to do 800 meters, 3 lights. That's 40 minutes. Scooter. So, it's a great pleasure to introduce Dr. Yu Weng-Chu. He came from Singapore. He's an expert in the tongue, so that he called his topic Linguadontics. So what is around the tongue. So the full body at the end. So he will talk about all. You have full day, but tell me at the lunch when you think to stop, to finish, so that I can think also how to feel. Because I have my part that I never finish. Because every time.
You let me know if you have time.
No.
If not, I'll try my best. Of course, it's too huge a topic anyway. So we'll delve into certain parts, and of course, I think we have experts in the field also in the audience. So we can go a little bit faster at certain points, and we can spend some time discussing things, not just me talking.
She's expert in talk time. So look her. Okay? Thank you very much. Have a great day.
So, thank you, Professor Olivia. It's very, very, very grateful, and also it's my honor to be able to present here again. I think this is a very interesting topic, which I have delved into it for quite a few years now. Hope that I can use this opportunity to share my perspective from different fields of dealing with the tongue. So it can be really from early childhood, as early as a newborn, an infant, right? And from children, right, to young adults, right, and also geriatric science. And we will deal with it from the perspective of growth and development, right? Non-extraction orthodontics, TMD management, and also sleep dentistry. Right, these are the few areas that I think we will find more growth in the area, right, over the next 5 to 10 years. So this linguadontics, right, literally is a term that I coined almost like maybe 7-8 years ago. And when I was just looking at it, but like so surprised, right? It's not found. There's no such word, right? So I said, okay, let's trademark it there. So I think the biggest objective is really to say, hey, can we make tongue important? And let's study this even early in our dental school, right? So I come from the garden city. We grow as many trees as possible because it's a very, very small island with many buildings. So we want it to be nice and cool and beautiful. And of course, this is one of our most famous landmark, the Marina Bay Sands. Right over here, you can really see a good view of our country. This is me many years ago trying to climb the mountain, and I feel this is also the whole journey that I'm trying to illustrate here. So when finally we get somewhere near the peak, but along the way it is not always smooth sailing. This is always the case where you really have to ride and pedal hard, right? And you don't know even what's in front of you, the curve and the turns and the slopes. But I think is to take one stage at a time, right? Compared to 10 years ago, right? I think we have definitely a lot more buy-in now. So I was just sharing with the digital, it's like in our country now, if you go to, later if I can get internet or search for you all to see, right? Myofunctional therapy, SingHealth. SingHealth is one of our national hospital group. And now they're talking about myofunctional therapy for helping with sleep apnea. So it has gone mainstream at least, right, for the medical side. For the dentists, I think there's still a lot of resistance for a good reason, because if we get this right and we do it really early, I think we're going to influence and impact a lot, especially in the field of orthodontics, right? We have less malalignment to deal with probably, right? So this Japanese word is mada mada, mada mada, right? So every time we cycle, they'll ask, "Are we there yet? Are we there yet?" She said, "Mada mada." Not yet, not yet. So the answer is yes, mada mada. Are we there yet? No. All right. We are far from it. We are far from it. That it is a general acceptance and a general provision of care in this area. So for me, my short history of the dental career, I graduated in '99. I did my fellowship. I did my implant certification. I trained and become a trainer, should I say, for Dentist Barcelona for CAD-CAM. I stopped in the year 2017. Reason is because I started with the red cam, then the blue cam, then the Omni cam, and then when Prime Scan came, I said, look, I have not paid back all my loans for all this machine. I'm not going to buy a new one so soon, right? So that's when I stopped training for them. Then I'll do my training in TMD, right? Temporomandibular joint disorder, or should I say neuromuscular dentistry, right? Over in US, flew in and out of Vegas too many times, I would say. And I went on to also get my mastership with WCRI, lecture for them, and presented at the MRCHQ in Gold Coast before, right? Also, I would call it honorary certification by Chris Farrell, right? For my teaching in the region of Southeast Asia. I think before I started talking about it, there's no other dentist actually lecture on myofunctional therapy using devices or trainers. Then I went on to give a TEDx talk, right? Wellness through the power of the tongue in 2017. So I think again, I beat many of my colleagues to become the first dentist to talk on the tongue, right, on this TED platform. So glad that it's still up there. Share it so that I can get my million view, but now it's still not. It's again mada mada. So we have Invisalign. So I have an opportunity to work with Invisalign for many years. Started using it in 2007 and lectured to the CEO Joe Hogan when they were in Singapore. They almost created the manufacturing plant in Singapore. Yeah, but we lost it because we have not enough land. So they moved to China. And of course the other one is in Mexico. And went on to do my sleep training task, and then of course very honored I can add one more now, 2019, 2022 and 2024 opportunity to speak over here with Professor. And then I'm still also very involved with Manchi, also in terms of how it is being used regionally. And then I'm also now the editor for the IJOM as well. So, and I also sit on the advisory panel for our oral health therapists, our nursing school. now it's my second term. What I'm trying to do is really to influence the board to give the OHT a slightly wider scope, right? To at least identify, if not hope to manage some of the myofunctional issues that they see in the early childhood especially, right? I took up one thing. I actually was on the how shall I call it? Faculty of Align. I teach for Invisalign, but because of my recent involvement with this material called Graphy, anyone heard about it? Yep, Graphy is a Korean product. Is meant as a material to print things that we can use in dentistry, right? And with that, Invisalign kicked me out of the faculty. So I think it's understandable. Okay, so basically we interact with technology very early. So almost very early adopter. Started using a laser in 2007. And yeah, so you can see this is my first laser, the Carbo Key 3. Right, it was such a tank, I would call it. Right, it was made to last. The handpiece is very simple but robust, and I used it for a few years. But the moment Danaher bought over the company, right, they scrapped the laser department within I think 1 or 2 years. So we lost all support and we moved on. So then I went on to get the other machines, right? So these are the timeline where I started involved with all these equipments and started learning. So DP Dental Director Academy, we have a whole holding company called Alphas. We put everything together. So I have, let's say, channel partners with Munchie, Myotronics, Myosport, Novotor, Bell & Ring, Star Aligner, and also the inventor of the Linguistic, which I'll show you later, right? Because it's always a team approach. So the clinical result by a group of passionate professionals, not just me alone, right? So everything connects. So again, I think the key point is to really recognize that, and tongue is actually a very, very important organ inside the mouth, which will help us to connecting together. But of course, like I say, it is not in our curriculum, right? Or that you do a whole chapter on the tongue. Maybe a few sections mention about it, and as dentists, we tend to push it away and deal with the teeth. We don't give enough respect and homage to this particular organ. So my own journey starts also from learning from Dr. Clayton Chen, my mentor for neuromuscular. Because the first thing that got me to this is really I have my TMD issues, right? I have neck ache, hip pain, grinding, cracked tooth for a good many years. 31-year-old to 37-year-old, constantly in pain for my hip. So I always ask the question, why am I suffering this? So when going over to learn about neuromuscular rebalancing, I start to realize, yes, my bite is off, especially the posterior region. I have a lot of vertical deficiency. So my teeth are not tall enough. So then the question is, why my teeth are not in position? Why my alveolar bone is not in position? Why is my joints are not in position? Then it came and dawned to me that, oh, maybe something about this, not just getting the bite, but also Dr. Herman Ramirez at that time also came by, lectured, and gave me an inkling that maybe the tongue has something to do with it, right? So it's 2015 at that time, it's almost 9 years ago. So at that time, then from the neuromuscular point of view, from a myofunctional point of view, then I start to realize, okay, if my tongue is not in position all my life, because I've tongue tied since birth, my mom can't breastfeed me, so she blame it on drinking some soup, and she has no more milk, right? And I grind my teeth a lot. In school, my friends refused to share the tent with me because of the grinding sound, and in military, we shared a barracks, and they really heard me grinding every night. And finally, they decide to look for this sound and found that I am the one that's creating it instead of the rat that they suspect, right? So this has been with me for so long, but the real problem really hit me at 31 years old, right? And I went on to see doctors to ask, what's my problem? And they say, okay, you're a dentist. You are having this bending, so it's occupational hazard, right? And do you play any sports? Yes, I play football. Okay, injury, right? So you add all this up, that's why you have the pain. But ever since dealing with my bite and dealing with my tongue tie twice, so only at 40 years old, I did my first tongue tie release, right? And I learned to extend my tongue, and at 44, I did my second round. Now I'm 50, I think I'm due for another round. So this is my maximum mouth opening now, you can see, and this is my extension. So I can do a full extension at full mouth opening, but you can see the tension. It's there again. It's there again. So if you study yoga, or should I say pranayama, right? They talk about this thing called kachari breath. Yeah. So you have to put the tongue up into your nasal cavity from the back of your throat. You can train until you can do that, and you can actually choose to breathe with your left or right nostril. And with that, you can control your yin and the yang, or your sun or the moon. Okay? And to do that, you need to train, right? Sequential tongue tie release, train sequential tongue tie release, and be able to do that. So maybe one day I'll be able to reach that point. But at the moment, I would still say from the tongue restriction, I still have my restricted mouth opening. So typically for ladies in the 40s, 40 mm and something along that line. For the guys, about 50, yeah, I used about 30 plus. So you know when you're in the 30s, you have a TMD issue with joint restriction. So after I gave my lecture in Taiwan, Marjan Jones heard me and say, why don't you start talking about, or should I say, helping out the babies as well. So that was in 2016, which I then went on to learn about infant tongue tie release. Yeah, and I provided the care for almost 2 years. And that talk, this was also a very interesting moment where ICAP had the first meeting in Toronto, right? I was very fortunate to really speak with the good colleagues who are also a good representation of the field then. But immediately after this event, I came back to Singapore. I was banned from doing infant tongue tie. Exactly. Just a letter came, right, to just say it is non-evidence based, right, cease and desist, 14 days, cease your operations for all babies tongue tie. Yeah, and of course I have to fight to clear my name for the next 2 years against my board, which is really a utter waste of time, resources and money, right, to just get back to the same point that I'm right in the first place. But it is difficult, and I'm not alone. Many colleagues in the field has gone through that, the baptism of fire, and also I'm very grateful that Professor Libby was one of my referee who wrote me the defense testimonial, which of course is very, very helpful to get me out of this situation. The other person was Dr. Zagi and also Dr. Scott Segal from New York University. Then there was the first time opportunity to come and lecture. We just spent some time in Nagoya, Japan, also 2-day program. And before this trip, I was just down in Australia, right? We were sharing this in terms of the data oral issues. So Sun Simin is a Chinese physician. So he talked about 上医治未病, 中医治愈病, 下医治已病. So simply is that, you want to do prevention, right? As much as you want, you treat the person before he gets sick, right? So that means you provide all the advices, right? So that they can totally be healthy and not be sick. then you're the top doctor, the best. Then of course, you also have doctors who will treat the existing one, right? But I aim to become preventive. So we know a lot of the things that we are studying now, based on just simply all the research, is a very linear model, right? Cause and causation. And if we try to say that certain things are really related to each other, right? We find it very hard to prove at times. So all these models are there, but our body is not so stupid to just keep just one simple step forward. It has so much linkages that it goes and cover up everything. So even in the field of linguadontics, these are just a few things that we talk about, right? In terms of pediatric science, right? We deal with the young infants and children, right? We look at orthopedics, right? We talk about neurology later. And of course, respiration to me is one of the most important part, right? Lactation, sleep medicine, gastrointestinal, just to name a few, right? So in 2018, we set up my second clinic, and this known as the Linguadontic Clinic. You can see this. This is actually the word tongue. You'll see many of this logo, like the very first page, right? Yeah, this very first page. This is actually the Chinese word tongue. Yeah, stylize it, and then it became a logo. All right. So I created a tongue clinic in Singapore, in probably the first in Asia as well, and probably one of the few in the world that is really dedicated to the tongue. But again, within a very short period of 8 months, right, after setting this up, even when I'm applying for the license, right, I mentioned very clearly tongue tie release for infant, myofunctional therapy for the children and the adults. I got my license, I practiced everything above board, I don't hide in one corner. Yeah, there's no black market for anything, all right? And I charge basically, there's a MediSafe. It's like some kind of a safe insurance that we have in our country. So a mother with a child with a tongue tie, they come to us. All they need to do is to just sign the form, and everything for the payment for the tongue tie release will be paid for, right? And we charge $650, which is not much, but with 3 nurses, $100,000 laser, and a whole practice to deal with one baby 1 hour at a time is not the best business, right? But it's the best thing that I think I need to do at that time. But the but is I did it too well, I feel, right? So very soon we become the referral center for all the parents. Everyone online will say, come to us. Why? First thing, they don't have to pay in a sense. Second is that we use the top lasers. Yeah, we follow all the protocols. I share it all online, shall I say, during my lecture. That's why Professor knew about it and dared to even stand up for me, right? Yeah, or else I would have no chance. So we saw 400 babies in 2 years. Every year, 200 babies. In Singapore, you have about 20,000 births a year. So 20,000. Yeah. So we are about 1% of all the births. And that it could be the incidence rate of all the tongue tie at that time. So we mop out all the tongue tie cases in a sense, and it came to us, and all the rest of the specialists must be wondering, what is going on? Yeah. So I mean, it's conspiracy theory. I'll never know the real reason why they target me alone, because I'm the only one in Singapore that cannot do babies. Everyone else can, except me. Exactly. So after I finish, I won my case. They still throw in one more spanner in the whole works and say there's no guidelines written. Okay, so because of that answer in the letter, the insurance company refused to cover me. That's it. So I can't touch babies because there's no insurance for medical protection at all for me only. Yeah. So I think, but again, thankfully over the years, I feel that it's a little bit more support and more colleagues are opening up all this. We have one in You see Richard Baxter. We have also one in Israel at the time. Also, we have also one in Ireland. Yeah, many of these tongue tie centers are being set up. So I feel, I think going forward, this will be Mada Mada. Okay, Mada Mada. Because even at this last week, shall I say, that's last week, when we were presenting, there's this gentleman, Dr. Angus Cameron. He came on to say that he is a scissors provider, and with that, he went on to showcase many videos and slides about very inappropriate use of laser for tongue tie. Yeah, so, but it's a very, very targeted smearing campaign to me. So
Who is this?
Angus Cameron. Anyway, I will share more later. But the fact is that there's still this situation at a meeting like the STOT, right? Which I feel, we don't need to do that. I feel we don't need to do that. We all can do good work. So that luckily, I have another presentation the following day, so I have a chance to explain to my colleague what is the right way to do using a laser, right? So, but I feel there's still a lot of resistance for good, for bad, we don't know. We really don't know why they want to stop this. Yeah, because deep down we know, especially as laser user, you know what is fantasy dentistry, right? Yeah, what a laser can actually do for you. A crown lengthening, you don't have to raise the whole flap. You can just do a sectional. You can do osteotomy. You can do so many things with it. Yeah. So the uninitiated, they are not sure, and sometimes that brought fear to them, and then unfortunately it translated to information that is not right. But we have to just move on. Like I say, with group of we start there, and like I say, after that my linguodontic clinic is no more. I can't call it Linguadontics. I can't even have that name used for my clinic. So I have to call it back to my DP Dental Orchard branch. That's it. Yeah. So even the name sick kind of thing gets to so much discussion with our board. Right? But you can see here, I put it as the centrality of the tongue. The tongue itself is a core organ that link up, all the other systems, because it has a very, very important role to play, which I will elaborate a little bit more. But in small print here, you can see there are many partners that we work with, from lactations, IBCLC, right, midwife doulas, osteopath, chiropractor, pediatric doctors, speech therapists, nutritionists, ENT, neurologists, just to name a few again, right? The whole village is there, all right? So we never work alone, and now we are definitely seeing more and more of this collaborative work coming online. Okay, so why is the healthy development of the somatogenetic system so important for breathing and facial development? I think we start with cranial nerves first, all right? So in the very, very beginning, even in your dental school, right, this is what you need to learn. And you need to apply this every day, even now. Yeah. So as you see your patient, the cranial nerve responses will give you a good indication what is actually lacking in terms of the coordination. So the somatosensory part of the body, really, we put a lot of allocation of real estate for the mouth and for the finger, right, or the head. So these are all very sensitive part. But truth is, when you're a newborn, you can't even use your hand to pick things up, right? You're all dependent on your mouth. So your mouth needs to make sure that you can cry, can eat, can feel, can reject poison, that anything bitter, spit it out, So all that is necessary to be on and also at the same time very early in your life. It has to work very well in order to keep you alive. Will this defense, this sensory part, this cognitive part is reduced throughout the years? I don't think so, right? It's still there, but other senses come online And then now you are more familiar with using your eyes, your hands to feel, but your mouth is still as important. So when we're talking about babies, you will say that there's a lot of this kind of reflexes, whether it's retained or not, shall I say, right? Retained reflexes or whatever. But you can see even just like swallowing, what kind of vagus nerve, right? Your facial nerve, your trigeminal nerve, all this has to be used. We deal with swallowing every day, right? Every moment, even. How is it done? So, as a baby, you will know that there is this suck, swallow, breathe reflex. Suck, swallow, breathe, suck, swallow, breathe, suck, swallow, breathe. That's all they do whole day, right? Feed again and then sleep. So all this is a tongue up response or reflex. Okay, so you see this baby over here and that one. Okay, he's sleeping, but we went on to just pry open the mouth, and you can still see the tongue stuck right up in the roof of the mouth. It just came down, right? So this baby is always mouth open, and you can see he's always protruding, and then he's ejecting, right? Mandibular advancing in that sense, trying to breathe, right? Yawn because he doesn't sleep well, right? And when he's trying to swallow, look at that, the whole face is required, the whole cervical areas. And now when I'm putting him on his back, if you can hear, he's just struggling. Yeah, he's having this very restrictive flow of air already. So anyone with a mouth open, with a low tongue, right, and you try to sleep, which baby will be like? This one, right? Of course, all of us would wish that we were just like the other baby, right? This one. And you can sleep like baby. Mouth closed, tongue up, you're breathing through your nose when you sleep. That's why this is key. Right at the very beginning of life, we already see this, right? And why this baby came to me for tongue-tie evaluation is not his fault. His mom actually had augmentation, right? Breast implant, make it really difficult for him to breastfeed. Hardly any, he can't compress at all. That's why he had problem. So it's not because of his tongue tie, but his mom's fault. But that's why I also have opportunity to see this baby, right? A normal baby coming to me, sleeping well, compared to all the other babies with tongue tie, they struggle a lot, right? So your cranial nerve is again supported by many other nerves, which is, I won't even be able to remember anyway. But it's just important for us to explore further, right? Deepen our knowledge in all these nerves and cranial nerves, right? In order to understand, hey, this function that we're always seeing, how it is done, right? If it's not done properly, what could be the problem? And then we start to track. So I'm always asking the fact is like this. If a light bulb is out, right? You can imagine some people will just come, oh, the light bulb is out. You kind of plug in a new light bulb and then just get it to go. If it's not working, where's the switch? They're like, I have no idea. Where's the DB box, right? The power distribution box. They have no idea. They have no idea how the wiring system works, right? That's most of us actually, right? So we need to figure it out. I'm still Mada here also because it's so complicated. I can only realize some things, and I start talking to many colleagues. Like for example, my physiotherapist. Then he will tell me, this muscle innervated by this, and if this is not working, the other muscles. Then I start to learn. Oh, okay. Then you start to have a little bit more inkling how the body is working. So we're talking about rooting reflex. So rooting reflex is very key point that helps me to understand certain things. So just now about suck, swallow, breathe, you notice we broke it down into these few parts where I do my discussion with the parents, why there is an issue. So I'll go into a little bit more in depth later, right, in a different part. But just to illustrate this one first. Okay, breastfeeding. So when a baby come near to mommy, right, he or she can't be able to really understand that this is feeding time. You just turn towards the breast and you just latch on and you will be fed. No. He is still figuring out what the world is, and he depends on his reflexes. So when his face touches the nipple, yeah, the trigeminal nucleus can then receive the signal from the facial nerve. Right? And this is enough to activate the accessory. Yeah, the accessory first, so that you can actually turn the head. Right? After turning, then you have your facial and trigeminal to do the latch on. And then after the latch on, you have your hypoglossal nerve, your glossopharyngeal, your vagus, to then coordinate as you feed, as you suck, as you transfer the milk into the back of the throat. How do you then stop, hold, right? Breathe, and then swallow, and then hold, stop, breathe, and swallow. You know, the whole sequencing, how does it work? Right? So it's all has to be that precise. One skip beat, you'll be choking. Right? So it's so intricate. But we just assume that it's just naturally, it will just work. If the tongue is restricted, so be it. No, it doesn't work that way. Right? The tongue needs to be there to do the job properly. So all 12 cranial nerves. Why 12? Like the olfactory, the smell, the scent of mommy, the scent of milk, the optic nerve, right? You can also see the areola. That's why the woman's breast is darkened and it's easy for the baby to really look for it, right? Vestibular new cochlea. So if you put a baby on the tummy, you'll be surprised the baby can crawl their way up to the breast to feed. So they can balance their way, suss out where the breast is, target the areola, then go for it, right? Reflex system, amazing. So with all this reflex system coordinating with your cranial nerves, right, you will then have to understand that they are actually doing one particular thing very accurately for you, and that is protection of the cardiopulmonary system. Okay, how long can a baby last if it's not feeding? Right? How long a baby can last if it's not drinking? How long a baby can last if it's not breathing? Yeah. So you can understand breath is so important, right? So must breathe. So everything that you're doing, you're eating, you're crying, is still circulating around the breath. They need to breathe. So that's why we need to protect the pulmonary, the cardiopulmonary system, making sure the air is open up, airways open up, so you can continue to breathe, and the life can continue. Right? So it's very important, all geared towards that. So when you have this thing in mind, I think what I'm trying to put forth is, if we talk about the tongue, we need to talk about the breath. Right? We're all about the breath. If we're not breathing, we're dead. Two books that I highly recommend. I can't finish reading them because I'll fall asleep reading them. It's heavy, it's really heavy. Stanley Rosenberg is still better off, right? But Stephen Porges did a fantastic job bringing this whole polyvagal theory, how the vagus nerve is so important from our response, our socializing, from a reptilian kind of transition to mammalian, right? How we have that. So a good read, but I say you fall asleep easily, but it's important. Okay, so the tongue. What the tongue does? Let's look at it. Okay, so this is a cine MRI of the tongue. Okay, So we need to put the tongue up to breathe, right? And open up the airway. You can see when the tongue is up in the roof of the mouth, right? Yeah, it is quite open at the back of the throat. Okay, over here. Okay, here. Yeah, so the airway is always open up, and then you can see good wide oropharyngeal space when the tongue is up. Also, you need the tongue to swallow, right? So I think, interesting, it's not looping well. Okay, going now. Okay, so as we swallow, I think I need you to just take note of this. See when it swallows, it will flush. Okay, I think all of us encountered this before. On the plane, you get your ear really blocked, yeah, and you want to just clear it. Sometimes you yawn, sometimes you just swallow. And when you swallow hard, it equilibrates a little, right? It clears. Actually, you need to do that every moment, every swallow. The moment you swallow, you equilibrate your ear. Every time you swallow, you equilibrate your ear. You clear your nose. So it's like a big flushing, all right? Nose flush, ear flush, throat flush. 2,000 times a day, right? So that's how. That's also one of the study that says that if you are able to manage this malfunctional effect, the middle ear infection is reduced or even treated without having to do surgery, put grommet, drain, whatever. If you can just swallow the whole thing through and through. Then of course, while you're at rest, the tongue is up in the roof of the mouth as well, right? So it has to be right up there. There you go, right? Touching the roof. And we always talk about tip of the tongue there, but it's not. It's the whole tongue, even the back of your tongue. And how I can tell whether your back of your tongue is up or not, I can just look at the back of your head. Yeah. So if your tip of the tongue is up, your head it can be still at this angle. But if your back of the tongue is up, your neck is straighter. Yep. So it's quite easy sometimes to communicate with my patient and say, oh, my tongue is up. I say, nope. You can see it. Yeah. But of course, it's tough. It's always I call it an argument with the patient, right, where the tongue is. So that's why we need to use some tools to help us along to get the position right. Alright, so we talked about this private spaces. This is big brother of the twin, right? You can see it's a very straight neck. Right, he stands, everything is all nice and straight. Tongue movement is good. Arch development generally good. Right? Even that said, I would say if he can expand a little bit more, it will be much better. Or else you see some of this imbrication in the lower and crowding in the lower. So when your tongue is up, your tongue pushes against the palate. It doesn't push against the anterior part, right? It pushes in the dome of the palate, in all directions. So you're not growing the anterior only, but you're growing the whole upper arch. So you need the tongue to reach for it all the time. And when your mouth is closed, this is also important to see, is that this part, right, the upper and lower lip is actually against the upper front teeth only. Yeah. When the mouth is open, the lower lip will slip down and sit on the front of the buccal side of the lower, and it will cause the tightening effect. And that's why you see some of this anterior crowding and imbrication. So you can actually move the lip up, you'll notice that you can actually create a lot of spaces. So these are all ancient scars, right? It's not that then the orthodontist is better than what we are doing now, right? It's all nature. So just from suck-swallow breathe, nursing, chewing hard food, being upright, breathing good air, right? That whole activity that you do with the body, right, is actually designed to grow like this. So the genotype is able to translate this type of phenotype, right? You notice there's a lot of wear on the teeth, but these are all very physiological, right? normal wear. They eat very hard food with grains, with sand in there, so they wear down their teeth. But as the teeth are worn down, the teeth super erupt into space, and it brought along the alveolar bone. So you can see the whole thickness of the mandible and the maxilla. Thick, it's very thick, right? They don't actually grind their teeth at night to create this kind of situation. It's all from function. That's why there's also time for secondary dentine to lay itself to protect the teeth, so they don't end up with a sudden, right, kind of endodontic problem, and they don't split their teeth as much as well, right? It's just worn. So you can see very large spaces, and I really like this kind of situation where you can see you have your first molar, second molar, third molar right in front of the ramus. More than enough space. Everybody can erupt. There's no need for the tilt and impaction. So how can we grow this again? I think it's going to be difficult, right? I think no parents we're going to be giving grains, uncooked food, you know, really tough meat for their children to chew on. Yeah. So we're not going to realize the full phenotype, yeah, but we'll get as close as possible. So you can see he has generally developed well with vertical, with spaces. Then this is his younger brother, right? So a big difference in terms of the vertical support. And from there, we can start to see that he has a little bit more forward head posture and a bit narrower. You see a lack of space already over here. More crowding on the lower. Still good tongue, no issues with restriction. So you can see from the two brothers, right, twins, we can see difference in phenotype. But genotype, I'm not. And no matter what I do to get him to stand up to take a photo, he will always be a little bit more forehead. Alright? And now my question. Yeah, so no matter how I take this photo, dental alignment, jaw growth, facial proportion, cervical, posture, airway. Now what are the links? Why? Why is all this linked up? So then come to this point. Yeah, it is the air that I talk about. So just now when we look at this whole airway, if the tongue is up, airway is open. And in this cine MRI, you notice that when the tongue is down, the airway gets very narrow. Yeah. So when we look at this whole craniofacial respiratory complex, we notice that all these different channels, yeah, they're all linked up. So if the tongue gets back low, block out the oropharynx, it makes it really hard. And sometimes when you take your SAF, you'll notice that there's a narrowing of the airway. Of course, it's still not diagnostic enough. I spoke to my radiologist, I speak to my ENT. He said, can we diagnose from this? Can we diagnose from CBCT? To them, there's still no paper out there that is able to say yes, right? Mada, yes, still. So at the moment, we all only can say there's some risks involved. We can't even make a conclusive statement. But common sense will tell you they need to breathe, right? So how can they then use all this cranial nerve again to get to the protection of his pulmonary system, right? So we do CPR. Okay, when you do CPR, you do a head tilt chin lift, right? Correct. So this is what CPR look like when he can't breathe. So if the airway is blocked, the person will do a head tilt chin lift. Look, if you look down, it's very narrow. You look up, it opens up. So you can see by moving the head up and down, the airway gets opened up or closed down. Alright? So when an individual has a low tongue, the mouth is open, then the tongue is blocking the airway, he needs to breathe, he doesn't know that he's actually choking himself in that sense, so he will depend on his responses, the body will then just do the yeah. So when you have a cervical spine, but then you have your lumbar curve that goes with it. So then you get into that kind of posture. Yes, sir. So when you see an individual, especially a class 2 individual walking into a room, most likely this is the posture. Yeah. And I always ask my patient, if you sprain your ankle, can you walk? Can you sprain your knee, can you walk? Sprain your hip, you sprain your shoulder, one is stiff and then you walk like this. Yeah, it's difficult, right? How about if you sprain your jaw joint? You can't walk, right? So let's not detach ourselves from the body, and we need to talk to everybody that we are part of the whole system, right? The dental department is not on its own. Okay. So, if we need to do this, forward head posture to open the airway, you see your Frankfurt plane will be compromised, right? Then your patient come and tell you, I got neck ache, hip migraine, and even like vertigo and ringing sound. Okay, imagine some patient comes to you like this, right? Okay, do you sometimes see that the head is tilted sideways as well? There's a side bend, all right? Because the occlusion, the bite is insufficient on this side. Okay, we will identify that again later on in the discussion. So if they come with this and this, so to the brain, this patient now is on a slope that is going up, that is tilted to the right side. Yes? Because the head is like this, and your balance system in there records that. But for him to walk, he can't be imagining that his world is slanted, right? He has to rectify it by putting it to horizontal plane. So his eyes will rationalize all this and tell the brain, you're on flat ground, just walk. Yeah. Then somebody will mess up the signal. The ear, the vestibular nucleus, or the eye. Somebody will say something that the brain cannot perceive. And then this will have a vertigo effect, I feel. Okay. So in order for someone to be healthier, we need to get him to this condition, right? Okay. So what do we do? Do we use the neck muscle to stiffen the neck? Actually, you don't have to. You just use your tongue. So it's like a forklift, like a car jack inside your mouth. You need to just jack it up. So once it's up there, it will support the posterior maxilla. Okay? And when it does that, it will have the effect to hold up the whole cranium. Do you know that your maxilla is the base of your whole skull? Yeah, it is. So if we just take this out, you're left with that. The tongue supports this whole cranium for you. So this is important, that the tongue rise up to the back, so that we can turn this back to horizontal. Okay? So, let's say for the longest time, right, we have an issue, right, discussing or arguing with the patient. Is your tongue up? Yeah, they say, oh, it's up, it's up. I can't see. We look at ultra scans, we talk about this to check, but it's still difficult, right? So, thankfully, Dr. Shihab from Australia came up with this. So, all we need to do is now stick it up to the roof of the mouth. I can mark out the spot for them. You choose. Either you want the incisor papilla further back, or sometimes we even throw up 2 spots, right, in order to get this position. Then, this is what happens, right? The patient is now able to put the tongue up. It supports the anterior part of the maxilla, and then this helps with the growth forward. Just a little. Yeah. So this is how it looks like, right? And the bottle is about 100 pieces. So I'll tell my patient, this is your 50-day challenge. Okay? Twice a day, put it up. and get it going. Later we can even try it out. Everyone, okay? It's vegan. Okay, if you want now, you want to try now?
Should I try?
Should.
Yeah, you should. Choose a flavor: banana or blueberry.
One.
One.
What?
You should demonstrate how to
Yeah,
do it.
I'll demonstrate. It's vegan, it's kosher, it's halal. So,
We have to take on the pallet and
but,
for how long?
it will stay there for 1 hour.
1 hour.
Yeah. Just in time for lunch, maybe.
1 hour.
Yeah. So basically, you just hold it in your thumb and just put it right to the top. Okay.
You have to pay us. You have to pay.
Okay. Okay. So
Ready?
it's okay. Okay. If it stays up there, perfect. Leave it on for a short while first. Okay. Yeah. Your palette has to be a little bit wet in order to do it well. Okay. And then just leave it on. Yeah. Don't press it first. Yeah, just give it a few seconds. Let it react with your palate, or should I say react with saliva on the palate, and it will become very sticky and will just stay there for the next hour.
And what do you do with it? Just leave it there.
Okay, I'll come to it. Just a moment. Let's get it up first. Everyone okay? It's up already?
Yeah.
Go ahead. Place it on.
You put it in the very top.
You put it at the very top.
You
Yeah,
produce this?
it's from Australia.
On the highest part if they want.
Yeah. You can choose your of course the highest spot is the best. Yeah, to my objective, right? But it might be difficult for patients. Yeah, because they can't lift or it's so narrow, it's very difficult to reach the spot. So sometimes you want it to be a little bit more forward for those cases. You might want to decide for them at the beginning, you want to make it easy for them to at least lift the tip. Then later you work on the back of the tongue. Because it's like, it's like yoga. It's not easy to do certain action well. Okay? So on the instruction, it will tell you to just put the
So it's easy to buy in Australia?
it's easy to buy in Australia. Yes.
Okay, I will ask to link to.
I will link you to Dr. Shiat, the manufacturer, the inventor himself. Actually, I just met him last week. I just met him last week. And now he came up with a nose strip and also a lip tape.
Potato practice.
Yes, for breathing, yeah. So definitely we want to have a system. Okay. So let's say you start off with the tip, but you want to aim for the back. Sometimes you will challenge a patient to have both, one here, so that they can feel the whole tongue up in the roof. I think I need to be prescriptive enough. You know what I mean? I want that whole tongue. Yeah, this is still not good enough picture. Sorry. The soft palate needs to be in contact as well. Not just the hard palate, just the soft palate needs to be in contact. That's how challenging it is.
The soft part?
Yeah?
I don't understand.
Come.
The whole, the back.
Now it's on the hard part.
Okay, no, your tablet is on the hard palate, yes. But when you touch the tongue up against the roof of the mouth, you need to get both up. Both in contact, meaning this. You see, it's touching the hard and soft palate.
Yeah.
Yeah, the tongue has to be touching the hard and the soft palate. There. Hard and soft palate.
That's the hard part. Yeah.
Okay, so once it's up there, I ask my patient to, you don't have to use the tip of the tongue to touch it because it's in the middle, right? You have to use the body of the tongue to touch it.
And then it forms the curve.
Then it forms the curve. Yeah, close the mouth, lips up, yeah, that's good. And if once you touch that, you need to even do a little bit of opening, lips together, but you try to open your, in a way, open, separate your jaw while the mouth is closed.
Teeth
Separate
not
teeth.
touching, just
Separate your teeth.
Yeah, separate your teeth without, and then you separate your teeth, separate it a little more. And you realize that it's not easy or the space is not much because we're used to it. Close, over close. But if we are doing it well, there will be a lot more vertical. So yes, so that is a tool that we can help to, like say, stop the discussion or shall I say argument with my patient where your tongue needs to go. Once I stick it there for them, sometimes I stick it for them, I just, okay, then I say, touch it. Then they go, now I know what you're trying to say. Yeah, because the spatial positioning is clear now. Right at the roof of the mouth, and then not the tip of the tongue touching it, the body of the tongue is touching it. If you can keep it there, you should be able to touch the palate and the soft palate. And then when you do that, yes, then you realize, yeah, your neck will be So the anterior part supports the front, and the posterior support extend your cervical spine. So sometimes you want to extend, you rather than just stretching your neck, you go your tongue and stretch your tongue instead. Go. You realize? Can you use your tongue and push your neck? Can you get a good stretch in your neck? It feels good sometimes, right?
It's actually having possibly an effect on your myofascial trigger zones points.
Definitely, definitely. Yeah. So when the tongue is in that position, is in the most neutral part of the body. Because the tongue starts from the center of the lower jaw, where it gets up there, goes to the center of the upper jaw, so everything is all linked up, everything is centralized.
So in prosthodontics, we speak about the neutral zone. Teeth have to fall in the neutral zone so they don't occupy the space of the tongue
That's right.
or the cheek.
That's right. So the thing is that the neutral zone is actually established by the muscles, right? So the tongue goes up, and then it will start to push those teeth. Just imagine your tongue as a big SUV, all right? When it parks into the correct rooftop car park, it starts to push all the traffic cones, which are your teeth, to the sides. Yeah, then you form the nice shape, yeah, for you from birth. Okay. Then your cheek and your lips will start to come in. The curtain of forces from your cheek and lips will be there, and it will be balanced. Then your jaw can not grow forever. It will just grow enough to be into that neutral zone.
Would you take into account the late mandibular growth between age 15 and 30?
Yes, yeah. Actually, sometimes we want to recreate that mandibular growth, or even maxillar growth, even. So how do we do it? We introduce orthodontics, right, to kickstart the whole reactionary acceleratory phenomenon, RAP for short. So we're literally creating micro trauma. The body repairs, and then as it repairs, allow for this to happen. So that's why we talk about putting the tongue up to grow the face. So you want Angelina Jolie's face, then we need to grow this. And this is the base of the whole pyramid of green bone, the maxilla. So when we talk about the maxilla, we are talking about this volume of bone that covers all the way from up here to the orbital area to the zygomatic arch, is now encasing the whole nasal cavity and going all the way to the back. How big is that bone? And who is in charge of this maxilla? Like this, right? Or the tongue, right? If the tongue is not up there, it's not creating that space, how are we going to create that volume? And of course, the discussion is still on extraction, non-extraction. Of course, what is the objective of aligning the teeth? Straight teeth, aesthetics, right? Some people, most, yeah, is that. But are we talking about function? Are we talking about functional volume of your nose? Are we talking about functional volume of the whole cranium that is being influenced by us? If we say no, then we are like, going in blind and we take out one part of the body and then we just say, heck the rest. Are we allowed to do that? Then, the nose always is producing growth as well as we developing. There's the middle nasal septum, right? Middle nasal. So your neighbor upstairs wants to build this majestic hall with this pillar in the middle. But he can only depend on you to renovate your ceiling, your rooftop, to flatten it so that he can continue to build. If not, in his living room there's always a little bump. And if you're not expanding, this bump is always there, the bone comes down and gets deviated. But if you can spread this, the middle nasal septum will grow. The face will grow, the cheekbone will grow, the nose will be prominent, and of course, even the eye socket. And with this at the base of the skull, it's going to influence the volume of the skull. Oh my god. I don't know what we can or cannot do with this whole idea, right? So we need the tongue to be up there 24/7, right? You only leave that spot when you are eating or talking, right? Every breath you take, 11,000 breaths, is up there. Every swallow, 2,000 swallow, is up there. Every rest is up there. So at least I predict about 15,000 contact points every day. So it provides craniofacial balance, it defines nasal structure, it opens airway. Okay, so that is the key why the tongue needs to be functioning. It opens up your airway to make your craniofacial component very open.
So would you say if the maxilla is well developed, horizontal axis, AP, anterior posterior, and sideways, there should be no DNS, deviated nasal septum?
Yes. Yeah. I dare to say that. Yeah. That's why now even there's many research coming out from US, especially with the Dr. Audrey Yun and Zagi Group, Sandy Liu, right? A lot of MAPIs, right? MAPIs, MSc. So we're expanding the upper arch really quickly with screws and all. Again, I'm always Mada. I'm cycling slowly. I'm not with a motorbike trying to go up to the Mount Fuji. It's not motorbike. You have to take time. The rest of the body needs to expand with you. You're not expanding one part, you're expanding everything. So give your body time. Yeah, that's how I see it. So the tongue can do it. Interestingly, of course, if you're a non-growing adult, okay, sometimes the word growth is so distracting, I would say. We are not able to grow, but can we repair? If I break my hand, I can repair my hand. So there's some repair ability the body can still go through, right? Yeah. Okay, so then another point comes to mind. Okay, so as dentists, how many joints are you managing usually for the craniofacial area? TMJ, right? Left and right. Okay, so this is what we are advised, taught, indoctrinated, right? How about I tell you have 3 joints to manage? Okay, let me explain. So your TMJ joint left and right, what joints, which jaw does it belong to? Mandible, right? So it is for the lower jaw only, for the mandible only. Then how about the upper jaw? Can you move your upper jaw? No, good point.
No.
Nope. Yes. When I drink, I'm already moving my upper jaw. right? So Indian culture, sometimes you want to drink without touching the rim, you do this. Or you want to chuck down a pint of beer. Okay? You move your upper jaw. So your upper jaw happens to be this whole thing, connected to the whole cranium. Yep. Possible? Okay? So if this is the case, then your AOJ is your articulating joint for your upper jaw. Yes?
I guess when you're saying, can you move your upper jaw, people, or I would think, can you move it separate, which basically you can't because it's connected to the cranium. So
Yeah.
that's why it's hard to.
I understand. Because we don't even think about it in the first place. Yeah. So now the question came, of course, quickly we will be like, But I'm just trying to say that, yes, right, if we think about it, it is possible to move the upper jaw with the whole cranium, right, as part of the whole system. And as a dentist trying to manage temporomandibular joint disorder, you have to actually manage the upper jaw joint first. Okay. Because again, if your upper jaw, your whole cranium, is not in that neutral position, horizontally, sagittally, right, and in the plane like this all around, then you start talking about where the mandible is going to go. It doesn't make sense. Yeah, if the head is still tilted or the upper jaw is slanted, the lower jaw is going to be out of position. So we need to settle AOJ number one before we talk about TMJ left and right. Yeah, and how to get TMJ and AOJ in the right position. That's it. When you put your tongue up into the roof of the mouth, front and back, AP position, suction hole, you'll have the best plane for all the three joints. I mean, you can play out yourself first before you. If you have a patient coming with a click, doctor, I have a click, I will click. Then you ask him open. Anyone will click now. Okay. So you try opening, closing your mouth. Yeah, you can feel a click. Okay. Now you try just putting the tip of your tongue to the roof and then open and close at the same time. Disappear. Yeah. Yeah. So TMJ fixed. Just, of course, it's not just simple as the tip, but it is just to show if your tongue is guiding from a start and end position, the whole orientation of your jaw, opening and closing pathway is changed. It's guided.
Police aligning.
Yeah. So your tongue doesn't allow for this. So if you grow up with the mouth open, the lower jaw will be like a boat in the open sea. Can be floating here, floating there, right? And then when the teeth are erupting, there's no fixed direction. So it's growing, then finally there's interferences. Then you end up with some, deflection here, interference there, crossbite, whatever. And then you have malocclusion. Then you start to say, oh, my joint is not having a good time. Yeah. But once you have your tongue guiding, everything grows very strictly, very prim and proper, like the royal family in Britain. Okay, so even in the Proverbs, they talk about life and death to the power of tongue. But yeah. Okay. So far so good.
Yes.
Quick question: what's AOJ?
Atlanto-occipital joint. Yeah. You have your atlas and your base of the skull, the occipital. So there's an articulating facet. Yeah. So that's the AOJ.
So tinnitus, ringing in the ear, as described as the problems with the inner ear. should also have
Yeah.
some influence
Yeah.
or more.
Yeah. So I get some patient referred to me by the ENT after they look through the structural and neurological issue of the patient and say that there's nothing they can do anymore. Right? Then they ask me to see whether it's related to the somatosensory tinnitus. So literally is the MSK or musculoskeletal type of work problem. So yes, the ear is just next to your TMJ. So of course, if any pressure, you can expect distortion, and that could be multiple from a physical or from period pressure or from neurological. So if we can recalibrate, yeah, we have a chance we can reduce it. But I don't tell my patient I can
With
cure
time, not
with time.
yeah. Slow time.
I tell them anything with your muscles, I can get you there quite quickly within the 3-month period.
Skeletal will take time.
Yeah.
Understand.
Yeah.
So you can also influence the posture, gait of a person
Yeah.
if they're walking
Yes.
a certain way.
Yes. Yeah. So now I'm doing a research with my university where we have the tongue and the slit that we measure, and after I do that, then they check on their gait and the balancing. So what we're trying to do is to see whether we can reduce incidence of fall. Incidence of fall. Yeah, how we stabilize the whole head. Yeah.
Do you want to take a break?
Okay. How about 5 minutes?